Hey, Jim Hoffman here for EMS Office Hours. This is your Monday Minutes. This, I hope, is going to be a little bit of an informative Monday Minutes for you. And I'm going to talk about asthma, especially when it comes to EMS and what we're doing as providers. And what I want to do today is give you more of some assessment keys rather than go through a whole thing about asthma and everything like that. I want to just give you some keys to look for when you are assessing your asthma patient, okay? You know, asthma is a very common call in EMS. We get it quite frequently, so that's why I'm trying to focus on some key elements here so that we can drill down to what you're looking for, what you can think about when responding to an asthma call, and what you can expect to find or what you should be looking for when you get to the patient. Okay, so I'm gonna go over to actual another screencast that I did to get away from the PowerPoint a little bit and make it a little bit more interesting, I hope anyway. So let's go ahead. I'm gonna flip on over to that and continue this week's Monday Minutes. Okay, so I thought a little bit different today, show my face a little bit. I even got a haircut for the occasion, and wanted to just, again, go over some of the assessment findings when it comes to checking your asthma patient. Actually, your assessment can start while you're around to the patient, okay, just by knowing what time it is. Because humans, we've got this circadian rhythm, right, that internal clock. It's naturally occurring anti-inflammatory hormones that we have are at high levels in the morning and they become much lower at night. So for this reason, asthma conditions sometimes can get worse during the nighttime, right? So if you're traveling to a call at night and you're thinking about that you're coming to an asthma patient, think about that effort, right? About those anti-inflammatory hormones that might be much lower, okay? Now, on initial assessment, you might find a patient sitting upright. They might be leaning forward with their hands on their knees, that tripod type position, okay? They're frequently, obviously, even sometimes using their accessory muscles to breathe. Okay, retractions might be noted. You might see them, they're having accessory muscle retractions as well. Now, some less obvious accessory muscle use you might see is of the abdomen, right, when they're using it for exhalation. So what you might want to try to do is you put your hand on their abdomen, on their stomach, as they breathe to see if they're having accessory muscle use, okay, in the abdomen. And the patient may also have a productive cough. You might ask if they've been having a productive cough. It might be reported as a thick mucus, okay? And you want them to cough that up. You want them to get rid of that inflammation, get rid of that mucus, okay? Some other things, that respiratory distress for that patient might be pretty obvious, right? A lot of times you can hear the wheezing, okay, without even using your stethoscope, okay? But now listen carefully when you do listen, when you have that patient regardless, okay? You don't want to just go by the fact you can hear it without using your scope, okay? Listen to all lung fields, anterior, posterior, and remember, you might have heard this before, not all wheezes are asthma, right? So keep in mind, listening to your stethoscope helps you figure that out, okay? Asthma usually has diffuse wheezing. It's heard in all lung fields on expiration, okay? Localized wheezing, so let's say you hear something in just one area of the lung, okay? Usually, this is going to be indicating it might be a foreign body obstruction or some other type of localized pathology, irritation to that lung area, okay? Rhonchi is something you might hear in the larger upper airways on inhalation, and a lot of times that might even be referred to as sort of an inspiratory wheeze, depending upon how pronounced the rhonchi are. Okay. Also, keep in mind that the person who goes from wheezing to no sounds at all is a problem, right? The absence of wheezing is usually pointing to the fact that patients go into respiratory failure. So some of the things you can remember when it comes to the progression of wheezing is you're going to hit expiratory wheezing first. You're going to have inspiratory wheezing after the expiratory, and that means that it's worse. becoming worse for the patient, and of course, like we just mentioned, that absence of wheezing or that silence, okay, is deadly, right? That silence means the patient is going into respiratory failure. Okay. Now, lung sounds can be misleading sometimes. All right, they are subjective. Depends upon your skill of listening with your stethoscope and your comfortability with that. All right. Now, something we can use in the field, if you've got waveform capnography, the one that you can use where you can put the prongs in the patient's nose and get waveform capnography with that can help you objectively when you're rating someone's asthma attack. Now, normal waveform, I'm going to put this up here next to me, are squared, like this one here, right? A normal waveform is squared. But now, an obstructive waveform, like you might see in COPD or an asthma type of a patient, some type of obstructive disease, is going to have a slope shape to it, like this here. I put this one up. Sort of a slope shape. You might have heard of a shark fin type shape, okay? And this can kind of help you a little bit when it comes to rating a person's asthma attack and figuring out what might be going on with your patient. One final thing to mention, guys, when you're assessing an asthma patient, again, these are quick keys that I hope you're going to be able to take away from this Monday Minutes, but one of the last things I want to mention is the heart rate, okay? A lot of times the heart rate is going to be increased as the tachycardia is really a common response to the hypoxia the patient is experiencing, and also the stress of the patient not being able to breathe, okay, feeling that ability to breathe, okay, so that their heart rate is going to go up, okay. Another possible find you might see in some severe cases of asthma is that Pulsus Paradoxus, okay. This is a condition that refers to that loss or a diminishing of their radial pulses on inhalation. Can be tricky to figure this out in the field. It's just another key, something else that you can look for, okay, if you're not sure what's happening with the patient. Okay, keep in mind that the Pulsus Paradoxus, what it is it happens as that increased air that's trapping causes an increase in the pressure inside of the chest. So when the patient inhales, the pressure rises. Okay, so the increase in pressure presses on the vena cava. It that fills the heart. It reduces the blood flow that's going to the heart. So as the blood going in is reduced, so is the blood going out. So that drop in pulse strength and even severe cases, maybe even blood pressure, okay, is that Pulsus Paradoxus, okay? Now, it could also be measured by using the blood pressure during the asthma attack, okay? The first systolic sound is heard on exhalation, and then you get a gap of, let's say, 10 millimeters of mercury or more before the sounds are heard on both exhalation and inspiration. Kind of tricky. Something you should look up, guys. Look at the Pulsus Paradoxus. See how you can use what's going on with that. And when you're trying to assess your asthma patient, think about how you can feel for those pulses, checking the blood pressure, and how that can help you diagnose your patient and clinically figure out what's happening with the patient. Sometimes it's pretty obvious with the asthma patient, right? Most of the time it's pretty clear they're having an asthma attack, they have a history of asthma, things like that. They're on medications for asthma. But some of these key assessments that I'm talking about today might help you if you're having a difficult time figuring it out, or you just want to go ahead and try to figure out the severity of what's happening with the patient, severity of asthma. So I hope you can use these Monday Minutes. I'm going to head on back real quick and end this episode and close this one out for this week. And I hope that seeing my mug here wasn't too much of a distraction. So let's go over and we'll check that out. Okay, so like I said, those are some key, I think, areas that you can focus on when you are assessing a patient who's having difficulty breathing. They might have an asthma history. They might not have an asthma history. You might not know whether or not they have an asthma history or not, right? So using some of these key elements, some key things to look for when assessing a patient, and when you're considering asthma and your diagnosis or your impression is kind of leaning you towards the fact that it might be having an asthma attack, I'm hoping some of these key points will pop into your head and keep you sharp and refresh your memory on some of the things that you can look for that are relatively easy when we think about it when we're out there in the field. Okay, I hope you can use these Monday Minutes as always, guys. I know I've been jazzing it up a little bit and changing the format. I'm still waiting for some key things to come in here so I can try to make these as interesting and as interactive as I can, for these short, quick little videos here. So if you have some minutes of your own, be sure to send them over to me. My information is contact@emsofficehours.com. This Monday Minutes actually is sort of a smaller part of an asthma area, training area, and information over at turbomedic.com. It's actually in the free member area. You don't have to be a premium member to access this. So you can go join as a free member and get the download of this content, the entire sort of overview of asthma and how to treat it out in the field, along with some other I think pretty useful resources to help you study and master the asthma patient and the presentation and treatment of asthma patients. Again, this is in the free area over at Turbomedic. Click this graphic here to go over to Turbomedic, and you can join as a free member there and access the entire asthma resources there at Turbomedic. This is just added. There's some other stuff there as well when it comes to respiratory drive and asthmatics and things like that. But this little section here I just posted. You'll see it in the new content area over at Turbomedic. Go click on this graphic or the link here to access, and you can join as a free member and access this content. So I hope I'll see you on the inside there. Again, guys, minutes of your own, send them over to me. Like I mentioned, my email is contact@emsofficehours.com. I like to go ahead and create some Monday Minutes on content and subjects that you are struggling with or that you feel EMS providers might need some more guidance or some tips on out there in the field. So go over and send them over to me. And until next week, as always, Jim Hoffman for EMS Office Hours and the Monday Minutes. Stay safe.